Hello, my name is Laura Maria Calderone, producer and host of The Long Haul, an online series of long COVID, where we speak to long haulers and their loved ones about their lived experiences with long COVID, and where we look at the signs of this debilitating disease. With us today, we have Dr. Jeremy Rossman, virologist and president of Research Aid Networks. Hi, Jeremy.
Hi, nice to see you again. Nice to be here today.
Nice to see you. It's been a while since we last spoke. It's almost June, year 3 of the pandemic, and there's actually a lot to talk about. So let's start with long COVID.
Sounds good.
So just to recap on the last months of what's been happening, the pandemic has almost exclusively focused on hospitalizations and deaths. And although obviously a very important statistics, they have overshadowed continuously a very important aspect that we in the long haul have spoken about before, just like others, and that is long COVID. Last week, there was an article from Stat News that clearly stated that omitted long COVID from the pandemic messaging has been harmful for public health. I'm just gonna read aloud a quote because it really encompasses the feeling that a lot of long COVID advocates and people that have worked with long COVID have thought. And that is that the omission of long COVID deprives the public of the knowledge necessary to understand the risks of various activities, make informed decisions about risk-taking, and understand what is happening to them if they feel sick for an extended period. With that, even before and after, there's been more news. Another one is Bank of England officials telling the Treasury Committee that failing participation in the labor market is not really a lack of job opportunities, but actually a rise in the long-term sicknesses linked to the pandemic, and that the issue of long COVID is very serious. We have seen such sentiment also reflected where you are at in the US and in other countries. A global study that was just published in April 2022 is doing the rounds again, as it looked at around 1.7 million patients worldwide that were infected with SARS-CoV-2, and it showed that the global prevalence of long COVID was 43%. So, Jeremy, what are your thoughts on all this? And just really take us through, where are we at with long COVID right now?
Unfortunately, this is something that we have talked about before, and we are still seeing and still really, trying to fight against. And that's the perception that the only relevance in terms of severity for COVID-19 is if you end up being hospitalized and the numbers of fatalities. But unfortunately, that paints a very different picture than the reality that's being experienced by the majority of patients. And part of that is really becoming skewed with treatments available like Paxlovid that are further reducing the number of fatalities. And so giving this perception that, okay, well, if we've gotten severe and fatal COVID somewhat under control, not perfectly under control by any stretch of the imagination, but somewhat under control, then, this is something that we can live with easier. But the reality is all of that description of severity doesn't touch upon long COVID. That is just severity of that initial acute infection. But when we actually consider severity of the disease as a whole, we have to look over a much longer time span, and we have to account for long COVID in that analysis. And when we do, we see a very different picture. For example, there's a recent report from Solve Long COVID, this nonprofit organization in the United States that was looking in the US. And what they saw was that between 7 to 13% of the population had some level of disability due to long COVID. And that actually between 2 and 4% of the entire US population had a severe disability due to long COVID. So this is having a tremendous impact. That's having an impact on the workforce. But they also estimated the financial burden that's coming from this. And they estimated that to be between 300 and 500 billion dollars. So by only looking at the acute severe disease, we're really missing the bigger picture of what's happening here in terms of long-term disability, both in terms of the effect on people's health, well-being, but also on that economic impact on the country as a whole. So really, by looking at that one specific aspect, we are ignoring the bigger picture. And it's really important that we account for long COVID when we talk about severity.
In these statistics that you just gave, it is looking at the percentage of people that got long COVID after COVID, but we're talking about one infection. What happens with reinfections?
This is a great question that I wish I could provide the answer to you. And because one of the things that people are really curious about is to say, okay, if you've been previously infected, or if you've been fully vaccinated or vaccinated and boosted, and then are exposed to the virus, well, what happens then? Are you protected against long COVID? And well, the answer to that is no. A little bit of protection, but not complete protection. There was a recent Nature Medicine paper that just came out that was saying that the protection from being fully vaccinated against getting long COVID only reduced the chances of getting long COVID by 15%. So there is some level of protection, but vaccines don't protect against long COVID. And that's something that's actually really important to be accounting for when we're considering this.
Especially because, again, this data is not specific to the whole world, because the whole world has not been vaccinated with the same vaccine or completely, fully. So that is also something to consider.
It's really important because you were mentioning this global prevalence study. And so one of the really important things about that is it was looking at prevalence in multiple regions around the world, and they were seeing, 40 to 50% prevalence depending on the exact region, but seeing consistently very high prevalence, very high levels of people that got infected with SARS-CoV-2 and developed persistent symptoms that lasted, say, at least 3 to 6 months long, and in many cases, a lot longer. Now, that those specific numbers do vary based upon study to study, but it does seem like the rate of getting long COVID is on average, 40% plus or minus. Now, the data that I had said previously between 2 to 4% being seriously disabled, that was of the entire US population. So that's not the percentage of people that got infected that developed lung symptoms, but these are the number of people in the US as a percentage of the population as a whole. So, this is having a tremendous impact, and the risks of getting long COVID, even if you have a very mild case of acute COVID, is incredibly high in countries around the world.
Yeah. And one thing that, when you read so many studies or researches or preprints or talk about them, discuss them, one thing that some people overlook or don't constantly think about is the fact that these studies are catching up to us, right? Because they are taking place in the past, talking about a situation that is during that time. So what you're telling us now, this was the findings of months ago.
Exactly. And it's really unfortunate because most countries in the world are not actively tracking long COVID cases. UK is one of the few countries that has an ongoing survey that does account for persistent symptoms, but the vast majority of the countries aren't doing this. Even the US when asked about this in a hearing with the CDC, they were saying that it was going to take months to potentially even years before they actually started to have some of that data on long COVID, and specifically long COVID in different waves with different variants. But that's because they don't have a system in place that's actively tracking it. Now, that's why we're sort of reliant on some of these other studies that have gone through and actually tried to get this data, because unfortunately, we don't have that ongoing metric for most countries.
No, we don't. And I mean, yes, you mentioned the UK, but which is obviously doing much more than other countries, but it's still, if you speak to long COVID advocates or patients, it's still not enough. So imagine the rest of the world.
Yeah, exactly. And I think that's a really important point, is that even the countries that we're hearing the most about long COVID, that we have the most data about long COVID prevalence, a lot long COVID symptoms, about countries that even have long COVID clinics and some awareness and recognition of long COVID in the medical system, like the UK or the US, even there, the support for patients is actually quite poor. You hear so many stories about patients that either can't get into clinics, have a very long wait, or get into clinics and really don't get much care, and don't get much support. And then, of course, even this awareness in the country isn't percolating down to the level of how risks of COVID are being communicated to the public. And so, yeah, they're doing better than some countries in some ways, but even the US and the UK has a long way to go to actually get to real support and awareness for long COVID. And like you said, a lot of countries haven't even formally recognized long COVID as a disease. So there's almost no recognition, awareness, or support in a lot of countries.
And it's also getting worse, right? As the protective measures that have been in place or were in place have decreased basically everywhere around the world, there's been more cases, and as we have seen, as logic dictates, right? More COVID, more long COVID.
Yeah, exactly. I mean, which is something that I've said, I feel like we've both said a couple times already, is that the best way to not get long COVID is to not get COVID. The more COVID you have, even if you're no longer as worried about hospital burden, the more COVID you have, the more long COVID you're going to have, and that this can result in long-term disability. And so it's a real problem, and it is getting worse. It's getting worse in terms of the total numbers of people with long COVID in any country, because this, of course, builds up over time. But like you said, it's also getting worse because of the rollback of precautions that are being seen in many countries right now.
And I mean, we're all tired of the pandemic. It's the third year, and so many things that we used to do before we can no longer do, or we shouldn't do, or don't want to do. So everybody wants it to be over, but you can't wish it away. We've tried. Doesn't work, right? But there's different things that can be done, right? One of the important things is ventilation, the filtration of air, so it's clean, because COVID is airborne. But another thing is seeing what treatments there are, right? Because if you can at least reduce the likelihood of getting long COVID. Can you tell us a little bit more? Because as Paxlovid was being communicated in news outlets, there was kind of a sigh of relief that went through social media and the news and governments, because like, okay, this is it, we'll be fine with such a treatment. But how easy is it to get it, and what is it exactly?
Paxlovid was sort of promoted as this game changer, that now we have something that works really well for preventing very severe COVID infections, for preventing hospitalizations, for preventing fatalities. And the data from the clinical trials really supports that as being a very effective drug for treating acute COVID. And that's great. That data looks very good. It holds up quite nicely. But there is a problem here when it begins to be translated into sort of daily medical practice. First of all, there's a very limited supply of that. Some countries like the US have bought a tremendous amount of Paxlovid. That has further limited the supply globally. And a lot of countries either can't afford Paxlovid or are unable to get the supply that they need. So that's the first thing, is that the supply globally is very limited. The second thing, and this sort of comes upon that limited supply, is that even in areas where Paxlovid is available, often it's only available to patients that meet a very specific criteria. Namely, in many places, they have to be tested by PCR and have to be PCR positive. So people that do rapid antigen tests often wouldn't qualify. You also have to be in a high risk group of severe infection. And to an extent, this all makes sense because you have limited supply and you want to make sure that it's going to the people that are most at risk. But the problem is that everybody's at risk. And so we want to have this available for everybody. But we have one other problem here, which is that we are now hearing about this idea of Paxlovid rebound, the idea that people take Paxlovid and then once they stop Paxlovid, they end up testing positive again and their symptoms come back. And this was not something that we really saw in the clinical trial in any significant amounts. We're seeing it a little bit more now. But of course, that's also where the translation to sort of everyday practice comes in, because Paxlovid is most effective the closer you get it to when you get infected. And so in the real world, by the time somebody might test positive, maybe by antigen, and then go back to get a PCR test, what are the delays? What are the lags? By the time they actually get Paxlovid, it's usually a little bit later than it would have been prescribed during the clinical studies. And so maybe that's one reason why you're seeing this rebound. Now, it's only a limited number of cases that we see this rebound. For most people, it's still very effective. But of course, the other interesting aspect of Paxlovid is people are wondering, saying, well, okay, this works so well for acute COVID. What about long COVID? There's evidence that says long COVID, at least in some people, might stem from having persistent virus that they weren't able to clear with their own immune system. So maybe if you give an antiviral drug, maybe it would help with long COVID. And in a very limited number of sort of reports and stories, we are hearing that taking Paxlovid does significantly reduce long COVID symptoms. So that's really interesting and really great news. But unfortunately, what we're seeing is that in most of those cases, when they stop taking Paxlovid, those symptoms come back. So is that because maybe they needed a higher dose or a longer time course of Paxlovid? Or is it because Paxlovid sort of helps symptomatically, but doesn't do enough to cure the disease? We don't know. But of course, we also have that issue that Paxlovid is only being prescribed and used in a very limited set of circumstances. And that is specifically licensed for acute COVID. So if you have long COVID and go to your doctor and say, I would like to try Paxlovid, chances are you're not going to be able to get a prescription because it's not approved for use in long COVID. So we are still waiting for that long COVID Paxlovid research clinical study to know how effective it is and hopefully be able to get some licensing for long COVID if in fact it works, and it might not.
Especially because there are so many scenarios, right? As you were speaking, I kept on thinking, okay, long COVID patient, but what type of patient? How long have they had long COVID? And what if they're taking Paxlovid and they have long COVID and get reinfected? What happened? It's a lot.
So many questions there that we don't know. We don't know about the reinfection. We don't know about different variants. We don't know about, if you have certain classes of symptoms, if something like Paxlovid would be more effective or not. And this is, of course, why we need these clinical studies to actually go and evaluate Paxlovid in sort of very carefully defined circumstances. Unfortunately, we just don't have that yet. There are some studies that are ongoing that are sort of adding in a little bit of data. But as of right now, we don't have any clinical studies that are ongoing that are specifically looking at Paxlovid or any other antiviral for long COVID. And so that's a problem because this is important data. It might not work. I'm not, don't think that this is going to be a cure, but it's an interesting one that has some evidence and rationale that it might be helpful. We just really need to see, is it, and how well does it hold up?
Yeah, a lot to look at. So someone that has long COVID, what can they do right now? I know obviously it is based on their personal situation. So what country they're in, do they have healthcare? Do they have money? But putting that aside, and obviously if that country acknowledges and supports long COVID, is there something that they can, I don't know, take or say or do?
Unfortunately, the answer is no right now. And this is a huge problem. Is we've had a fairly long gap from the last time we talked, and there's been a huge amount of studies that have come out in that period of time. We know more about certain aspects, but it really hasn't changed where we are for a patient level. If a patient has long COVID, our ability and what we can do about that is still incredibly poor. There's still cases for, so patients advocating for more research, for more treatment, for more awareness. Patients, definitely need to go and hopefully try to talk to a supportive doctor. Whether or not that's possible is a whole nother story, but hopefully be able to talk to a supportive doctor, because long COVID spans such a range of conditions. And so, some patients might have, issues with clotting, or might have cardiovascular issues, or might have things where there are some aspects that can be, treated to some level. But in terms of long COVID disease overall, no, we're unfortunately at that point in time where we still don't have an answer. We don't have a therapeutic, we don't have a treatment protocol yet, and we desperately need it. There are so many studies that have come out that show a little bit of evidence of this or a little bit of evidence of that, but then off or sort of reports coming out of little bits of data, but we're nowhere near that point of being able to say, yeah, we have somebody that works, and it works for either all patients or this group of patients. I really wish that I had something different to say for that, but the number of papers that are coming out, the number of studies that are ongoing into long COVID right now is huge and has dramatically changed over the past year. So I do have hope that something will be coming, but we're not there yet.
Yeah, for sure. Hope, especially because as how we started the episode, there's more awareness in government and in news outlets that it is a problem in every aspect for a society. So
Exactly.
let's see. So is there anything else that you'd like to say on the status of long COVID before I go to the next?
Just to say that there is a lot of research that's coming out all the time, and we are learning more little bits about long COVID. There are a lot of hypotheses about what might be causing long COVID, whether that's persistent virus or clotting disorders, but we're nowhere near the point of being able to say, yes, this is what long COVID disease is, and this is how we treat it. But the one thing that I just want to say is that we are getting closer. We are working our way there, and the number of people that are working on this is really large worldwide. So we are getting closer, but there's still a lot more to do. There's still a long way to go, but also there's still a lot more advocacy that needs to happen. There's a lot more awareness that needs to happen, a lot more push for governments to recognize and to commit to funding and supporting long COVID. So a lot that everybody can do to help push this forward.
Yeah. So we spoke already a little bit about the situation pandemic-wise, but I wanted to talk a little bit more, especially because, since the pandemic began, we've seen every time new variants, new consequences, and new changes in different countries. So we're right now with the Omicron variant. So let's do a quick recap of how we got here. At the end of November 2021, there was a new variant, B.1.1.529, that was reported to the World Health Organization. That was because of the excellent surveillance work of Botswana and South Africa that had first detected. And that's one of the things that a lot of health organizations have continuously said throughout the pandemic, that it is very important to be aware of what is happening, because otherwise, how do you prevent, right? So 2 days after it was reported, the World Health Organization named this new variant Omicron and classified it as a variant of concern. Within weeks, so beginning middle of December 2021, the narrative that Omicron was mild was seen around everywhere: social media, news conference, from governments, articles everywhere. Some were still asking for caution, as it was too soon to tell, and the virus had not been that nice up to that moment, so why would it be? In January, the World Health Organization began to express their views, saying, there was a danger in repeating and thinking that Omicron was mild. And as Omicron continued to infect people, causing hospitalizations and deaths, we saw that weeks turned into months. And indeed, there's been papers and studies in the last weeks and months showing that in the end, it's pretty much the same as other variants. So can you just walk us through how Omicron has evolved? What does it mean right now? And especially because we've seen now it's not only this specific Omicron, but there's sublineages. So what does it mean, and where are we going?
Yeah. So, I mean, the first thing to remember is that, of course, we've had a lot of different variants. And only when we sort of, the variants get to this, really sort of important variants of concern stage, do they tend to get the names. But we've had Alpha, we've had Beta, we've had Delta. There have been a bunch of others in that period of time too that people were concerned about, like Mu or Lambda or things like that, but that didn't end up really taking hold on a global level. But Alpha really did, made a huge impact. Beta did in some countries. Of course, Delta had a really catastrophic impact across the world. And then Omicron really did. And one of the reasons why Omicron was really having such a catastrophic impact was that it was a lot more transmissible. Because we talk about, or you hear a lot about this idea of, okay, well, is the virus going to evolve to be less dangerous or less severe? And of course, it's possible that any one new variant might be more or less severe, but viruses don't defaultly evolve to be less dangerous. That's not typically what happens. It can, but it doesn't have to. But what does tend to happen very consistently is that viruses evolve to be more transmissible and to evade the immune system. And that is very profoundly what we've seen with Omicron, that Omicron is more transmissible and is very good at evading the immune system. And this is where we really started to see problems, because people that were fully vaccinated were getting infected. People with boosters were getting infected. Now, part of that is because the immunity from the vaccines does tend to wane. And so there was a fair bit of the population that had maybe been 6 months or more since their last dose of the vaccine. And so the immunity had waned a little bit over time. So they weren't as protected. But also Omicron evades immunity and spreads even better. And that's why it's been such a problem. But it was even more of a problem because of this narrative saying that it's less severe. And that came from a lot of hospital data of actually saying that Omicron was causing a lower rate of hospitalization. And that did bear out to some extent, but Omicron's not much less severe in that category. And importantly, as we mentioned before, this argument of saying, is Omicron more or less severe, only pertained to hospitalization and fatalities. It did not pertain to long COVID. And we know that a lot of people have gotten long COVID from Omicron. But what has happened now is, well, exactly what you would expect, is that as long as we keep getting infections, the virus keeps changing. And so what do we have? We have new variants of Omicron that are coming out all the time. So the sort of original Omicron is now called BA1. And right now in a lot of countries, in the US, in the UK, we are having a wave of BA2 or BA2.1. And this variant is even more transmissible and even more immune evading than BA1. So again, it's continuing to evolve to be more transmissible and more immune evading. Now, the problem with this new variant is, of course, that, well, even people that were infected by BA1 can be infected with BA2 or BA2.1. And even people that have had 2 doses of the booster of the vaccine can still be infected. There's still a lot of protection that comes from the vaccines. It still dramatically helps reduce severity and hospitalization. But of course, it doesn't have a huge impact on preventing long COVID. Now, at the same time of having this BA2.1 wave, countries have released precautions. And so now we are getting rampant spread of a more transmissible virus that still causes long COVID and can even infect people that have been fully vaccinated and boosted. So that's a problem in and of itself, but that would be bad enough if we were just talking about BA2. But of course, you mentioned South Africa, and you mentioned the surveillance in South Africa, which is great. One of the few countries that's actually doing very good surveillance and publishing that in a timely manner. And unfortunately, they are now in a new wave also, but they're sort of a wave later, because they are now having a wave that looks like it's attributable to BA4 or BA5, which are further variants, further evolved variants of Omicron. Now, why these are not being called the next Greek letter, pi, I can't say. Will one of these end up being termed pi by the WHO, or is that going to happen later? I don't know. But unfortunately, what we're seeing with BA4 and BA5 is even further immune evasion and possibly even more transmissibility. So you can't be relying on a previous infection, even of Omicron, to protect you. And you can't be relying on vaccines or even vaccines with boosters to stop you from getting infected. Of course, that all still helps with severe infections, hospitalizations, and fatalities, but it doesn't help a lot with long COVID, and it doesn't help a lot with stopping the transmission. And so what we're looking at now, if we're looking into the future, we're looking at a point where, okay, we're having a BA2, BA 2.1 wave. Well, we're most likely going to have a BA4 or BA5 wave. And then what comes next? Because with so many cases worldwide, the virus keeps evolving. And so we are going to have another wave, and then we're going to have another wave. And we're not doing anything right now that is going to stop that anytime soon. Now, we might have a new vaccine sometime that completely stops transmission. That would be great. We might have an antiviral that does the same thing. That would be great. Or maybe some countries actually keep those precautions up and keep recommending mask wearing, keep recommending, ventilation indoors, things like that, and really slow the transmission. But the way things are right now, we're going to keep having waves, fairly low levels of hospitalizations and fatalities, but those will still occur, but continually dramatically increasing numbers of long COVID patients.
Yeah, both. So increased number of long COVID patients, but also one thing that is, again, overlooked is the fact that any small number of a big number is still a big number.
Yeah, it's a really important point.
So we can't keep on hoping, right? As a plan, hope is great to have, but it's not a good plan, at least not in a pandemic, and at least not in what we have seen. So
exactly.
So this episode is a little bit different than the rest, because although we have obviously spoken about the situation of long COVID and the pandemic, there are a couple of things going on in the world right now that are worth a mention. The first one is hepatitis. So from October 2021 to February 2022, there were 9 children in a hospital in Alabama in the US that were identified with severe hepatitis of unknown origin. At the end of March 2022, Public Health Scotland was notified of 5 children between the ages of 3 to 5 with severe hepatitis of unknown origin. Days later, the UK informed the World Health Organization of these cases and a few more. Within a couple of weeks, the cases reported worldwide were around 450 cases, and all were children under 16 years old. And it was estimated also that a certain percentage of them had required liver transplantation. Tell us about what's happening with this hepatitis. First of all, why is it considered a severe hepatitis of unknown origin? And yeah, what's happening?
So this is a sort of scary development, and we don't really have a lot of answers right now. This is still very new, and people are really still trying to figure out what is going on. What this is sort of rapid onset, very acute, very severe hepatitis that will often bring children to the hospital and need intervention. And children getting severe liver damage is relatively rare. This is not something that happens very often. It can happen. But the sort of really confusing thing has been trying to figure out what is the cause here. Because, when we think of sort of rapid onset, very severe liver disease, it's usually correlated with things like a hepatitis virus, which unsurprisingly causes hepatitis. But when they went and looked in the children, they didn't find any of the hepatitis viruses. So that was a little bit confusing. And so they were looking and saying, okay, well, is there some other virus or some other infection, or maybe even some environmental contaminant that is causing this? Now, not necessarily ruling out, but sort of leaning away from any environmental contaminant, is that we are seeing these cases in multiple places around the world in a relatively short period of time. So that does suggest that maybe there is some infectious disease going around. And what they've seen is that in the majority of cases, they are actually able to find evidence of something called an adenovirus. And adenoviruses is that it's a viral family unrelated to COVID, but it's another big virus family. And most of these viruses might cause things like the common cold or be very, very mild. Some can be a little bit more severe, but they're finding a very specific adenovirus that they didn't previously think caused hepatitis. And it's also not perfect because they're not finding that adenovirus in all kids. And so it's not exactly clear. Now, one of the sort of obvious things that everybody was asking is, well, is this COVID? Is it maybe, say, BA2 now causing hepatitis in children? But when they looked for COVID, they also weren't finding COVID in most kids. In a few, they found COVID, but not most. But one of the sort of things that is a big question mark here is that a lot of those kids had been previously infected with COVID. And of course, the children that didn't test positive for antibodies to COVID might, of course, still have been infected, because we do know that most children have very mild acute COVID disease and can even be very easily asymptomatic. Now, they can still go on to develop long COVID, and some kids do have very severe disease, but overall, the symptoms of the acute disease are relatively mild. So people might not know that their kids were infected. And if the antibodies only last for a couple months, then they might not show up on those assays. So we don't know if all the children that are infected with this adenovirus and that have this acute hepatitis have been previously infected with COVID or not. So it's a bit all up in the air, but it is very curious to say, okay, well, we have all these cases of COVID that are happening now in children, that are happening with a virus, maybe, that we didn't previously know to cause hepatitis. And that's happening in the middle of a pandemic. So there's a very real possibility that there is a relationship with COVID, but we don't know for sure. It might not be, it might be another virus spreading around at the same time. But one of the reasons to think that maybe there is a link to COVID is that we know that COVID infection causes a dysregulation of the immune system. And that when you look at long COVID, but even when you look at sort of healthy, recovered, post-infectious period people, there are persistent effects of that immune dysregulation, that the immune system does, in some people, reset, but sometimes it can take months before that happens. And in the case of long COVID, that persistent immune dysregulation may occur. So one possibility, and this is purely hypothetical right now, but one possibility is that COVID infection in kids caused some sort of persistent immune dysregulation that affected how this adenovirus interacts with the body, such that it now caused severe acute hepatitis. That's one possibility. We don't know. It might not have anything to do with COVID, but it is very hard to rule COVID out, given that there are so many cases worldwide, so many children have been infected, and we know that the virus can cause some level of immune dysregulation. So it may be related, it may not, but right now it's a big unknown that a lot of people are looking into.
And that is actually the perfect way to go to the next topic, which again, it is something strange happening, and it's monkeypox. So in the last few weeks, we have seen more and more news on monkeypox. So let me just give a little recap on how we got here. So monkeypox is endemic to West and Central Africa. And actually, after 4 decades without any cases, in 2017, Nigeria experienced a very large monkeypox outbreak that is actually still ongoing right now. And the outbreak emerged out of nowhere, and the world paid very little attention to it then. And only now, because of what is happening in the world right now, the international community is looking into, yes, what happened in Nigeria 5 years ago. In non-endemic countries, one monkeypox case is considered an outbreak. And in early May 2022, so this month, the UK confirmed its first monkeypox case, a man that had traveled to Nigeria and returned to the UK. May 14th, the UK Health Security Agency announced that there were now non-travel related monkeypox cases too. The only major monkeypox outbreak to be recorded in the global north was in 2003 in the USA. And as of now, there are cases that have been identified in over 20 countries, and there are almost 300 confirmed cases and more suspected. Outbreaks happening at the same time in different countries is very strange. Tell us a little bit more of, first of all, what is monkeypox, and what does it mean to be seeing these outbreaks in so many different countries right now, and especially, in the middle of a pandemic?
Yeah. So, I mean, I think a really important point was something that you mentioned, that this is not a new disease. This is not, we're not seeing the emergence of a brand new disease that we've never seen before, even though a lot of us will never have heard of monkeypox before. This is a disease that's been around, that we've known since the 50s. And as you said, it's endemic in West and Central Africa, where it causes cases that are usually thought to be caused by contact with wild animals that might have this monkeypox virus, and then it transmits to humans. And then you can get human to human transmission, but it's not thought to be very efficient transmission. So we're used to thinking right now about COVID, and we talk about Omicron and the different Omicron variants, where the virus spreads in the air very efficiently. Now, when you think about a disease like monkeypox, it doesn't spread nearly as efficiently as COVID. So it requires much closer physical contact between people, either physical contact or a little bit of transmission in the air, but tends to be only in very short distances. So what this disease is this is a pox virus. And so pox viruses are very different from COVID, very different kind of viruses. It's actually a DNA virus instead of an RNA virus like COVID. And these viruses cause pox, or basically sort of blisters on the skin. So basically what happens is, if you get infected with monkeypox, you tend to have a fever, you might feel a little fatigued or have some sore muscles. You'll probably develop swollen lymph nodes, and then start to get a rash. And that rash will then develop into these blisters. And if you look online at any health authority website, you can see what these look like. And they can be very painful blisters. With a disease like monkeypox, they tend to occur sort of anywhere on the body, but mostly on the limbs, on the face, on the head. They can even occur in the eye. They occur in a lot of people on the soles of their feet, which can be incredibly painful. And some people will have maybe 1 or 2 blisters, and some people will have 1,000 blisters on their body. So it can be very different. Those blisters, though, can be highly infectious. And so the sort of most efficient way to spread monkeypox is through close contact. So like actually touching the blisters between somebody that has those blisters and somebody that doesn't. That can spread the virus very effectively. Also things like, if somebody's infected and then sort of their bedding might then spread the virus very effectively if somebody else touches that. So it's that close contact that spreads the virus most effectively, although some of it can also spread in the air in close proximity. So there's still a need for sort of more precautions than just that touching contact. Overall, the virus tends to have a relatively low fatality rate compared to really severe viruses, but actually a pretty high rate if you start getting a lot of people infected. So this version of monkeypox that's going around is thought to be a variant that has around a 1% mortality rate. So that would effectively make it higher than COVID, but it also doesn't spread as well. So it's unlikely that it's going to cause, a new epidemic or a new pandemic just because it doesn't spread as well. But the problem is that it can take 2 to 3 weeks from when you get infected to when you first have symptoms. And then once you start having symptoms, it can take between 2 weeks and 4 weeks that you can be contagious. So that offers people a large span of time in which they might actually be spreading the virus if they don't know about it and aren't taking precautions.
To make sure it's clear, are you saying that you are infectious only when you start having symptoms and then onwards?
It's thought that you're mainly only infectious once you start having symptoms. Now, we don't know for sure because monkeypox is a disease that's been around, we've known about since the 50s. So on one hand, we say, oh, well, we know a lot about monkeypox. But on the other hand, it's not a disease that has been widely studied. And we don't have a lot of numbers of people that have been infected before. So we don't have great data. So we don't really know exactly when people become transmissible. So it's possible that there is this window before, overt symptoms where people are transmissible, but also those early symptoms, that sort of fever and that little rash, you might not realize that that's monkeypox. If you're a little bit tired and have a minor rash on your arm, you might not think that it's monkeypox, but it might still be transmissible. So that's the sort of really concerning window, as well as people that develop full blisters that don't realize what it is. But when we start to ask the really pertinent question, which is sort of what we started here before I had this long dive into a little bit about monkeypox, was what's going on here? Why is this so different? Because previously, we have very, very small outbreaks that happen directly related to travel from West and Central Africa. Last year, we had a monkeypox outbreak with 3 people in the UK, where one person had traveled, also coming back from Nigeria, infected 2 others. There were 3 cases, that was it. Even the biggest outbreak that you mentioned in the USA only had 47 cases. So they tend to be very self-contained. But what we are seeing now is a lot of cases in a lot of different countries and a lot of cases that are not directly linked back to travel to West Africa or Central Africa. So the question here is, what is going on? And the short answer is we don't know, but there are a couple possibilities. So first of all, it's possible that with COVID precautions being relaxed in a lot of areas, there's been a sort of rebound effect of people traveling, people having large social gatherings, big parties, things like that. So it's possible that one or a few people did get infected with monkeypox in West or Central Africa, went to some, traveled some, went to one or a couple big parties, infected a whole bunch of people. They then infected more people, and that spread to many places around the world. So that's one possibility. Another possibility is that the virus has changed in a little bit, and it's now more transmissible in people. The evidence for that is weak. There's some reports saying maybe there are some small changes in the virus, but also there's sequence data that says the genetics of the virus is very similar to what we've seen in previous small outbreaks. So it's possible that the virus has changed, but the data so far on this is saying, yeah, that's probably not what's driving this. It's possible, but it's not most likely right now, although we don't have a lot of data on that. The sort of other possibility is that, the virus had actually been sort of spreading without much awareness in a couple countries over the past couple years, causing very mild infections, and that for some reason now it's sort of taking hold, maybe due to those relaxing precautions. That's a possibility, but I think that doesn't hold up quite as well either, because there haven't been reports of isolated cases of monkeypox in, say, the UK, not related to travel in years before now. So the final possibility gets back to our hepatitis story, which is that perhaps because such a large portion of the population now has been previously infected with COVID, there might be more sort of background level of immune changes in people, and maybe just short term, but given the number of COVID infections, that's still a significant number of people. And maybe those sort of short term changes in immune function either permit COVID infection more, monkeypox infection more, cause you to be more transmissible, or change the disease in some way. So again, just like hepatitis, there's a possibility that previous COVID infection sort of might predispose people to other diseases. Now, I really want to emphasize here that this is purely like one hypothesis of a lot of different possibilities here. But given that we do see so many people infected with COVID, given that we do see some level of persistent immune changes, it is a possibility, and it's something to be aware of, because that could mean we start to see other diseases occurring that we wouldn't expect, because the population might be a little bit more susceptible now. We don't know, but it's a possibility. It's something to work on. It's something to be aware of. And of course, something to be cautious about. But the good news here is, like we've always talked about, at the end, when we're saying, okay, well, what do we do about this? What do we do about COVID? What do we do about long COVID? What do we do about monkeypox or hepatitis in kids? The answer keeps coming back to the same thing, which is precautions. And those precautions are still the same. So whether you're talking about monkeypox, whether you're talking about adenoviruses, or whether you're talking about COVID, of course, the best thing you can do is to not get infected. The good news is that those measures that protect against COVID are really good at protecting against the spread of many other diseases. So things like masks, avoiding crowded indoor spaces, indoor ventilation, social distancing, all of that really plays a really big effect in reducing the spread of COVID, as well as many other diseases, including adenovirus and monkeypox, with monkeypox having that added issue of, people just being aware, looking for unknown rashes, looking for, blisters that might occur. And if you see that, immediately go talk to your doctor, but also just being cautious in that sort of close contact interactions with people. But in the context of COVID, we need to be cautious about close contact interactions with other people anyways. So this doesn't require saying, okay, we need to do something totally different. Again, we still know what to do. We just need to keep up those precautions, because monkeypox is around, adenoviruses are around, COVID is still around and going to be still around for a while. And whether you're talking about worrying about monkeypox or worrying about the incredibly prevalent rate of long COVID symptoms, or even hospitalizations and fatalities, we know what to do. And it's important to take those precautions yourself, for your family, and to remember that this affects everybody, that this is not just something that affects the elderly. This is not something that just affects, healthy young adults. Children can be infected. There was even a study that was just a preprint study that was just put out very recently, saying that COVID is now the leading cause of death in children in the United States. And that's not even touching on the impact of long COVID in children in the US. So we need to be aware it's not just fatalities, it's long COVID, it's disability, and that there are a lot of viruses to protect against, but it doesn't have to be complicated. We know what to do. We know what actions work. We just need to stick with those.
Yeah, because unfortunately and obviously the world has changed. The world, we are no longer in the world of before 2019. So we cannot expect to just ignore it. We need to adapt, and we have the tools. You mentioned ventilation.
Yeah.
So we know that air needs to be clean and keep on flowing and in indoor spaces. So yes, individually we can do some things, but it also comes down to governments, policymakers. Indoor ventilation needs to be improved. And one thing that is clear from everything that we spoke about today is that getting infected and reinfected with COVID-19 is not a good plan.
Yeah, that is the simplest core message here. It's not a good plan. It's not a good plan for anybody, and that there are a lot of measures that you can take individually for your friends and your family, but also a role for all of us in continuing to advocate for safety measures, for long COVID support and awareness.
Exactly. Jeremy, thank you very much. It has been a very interesting update episode, and hopefully the next time we will have much better news. And yeah, let's see.
It was my pleasure, and I really look forward to filming that episode where I can come on and say something really positive.
Same here. So take care, and yeah, this is it. Thank you.